Hi everyone, and welcome to today's webinar. I'm delighted and honored to have Dr. David Stukus from Nationwide Children's Hospital in Columbus, Ohio here with us today to talk about food allergy testing, what we as parents want to know. This webinar is offered by Kids with Food Allergies as part of its Education Outreach Program. I'm Linda Mitchell, Vice President of the Asthma and Allergy Foundation of America, Kids with Food Allergies Division, and I have the privilege of being your moderator today. Presenters of all of our webinars are doing so as volunteers without compensation, and on behalf of KFA and the Asthma and Allergy Foundation of America, I'm very grateful for Dr. Stukus to donate his time to be here with us today. I have a few housekeeping details to run through while we run a few polls. First of all, today's webinar is made possible through an unrestricted educational grant from Thermo Fisher Scientific. We rely on donors and corporate partners like Thermo Fisher Scientific for the financial support that enables us to develop education programs for families. And next, please remember that this webinar is of a general nature only and is not medical advice. You should consult your own physician for any medical advice you seek with regard to food allergies and other medical conditions. And if we mention anything by brand name or any food or ingredients or products, we're not implying that they could be safe for you or for your family. Please consult with your own doctors, and with regard to foods, of course, to always read labels and verify ingredients. Today's webinar is being recorded. We have a very large audience here with us today, and so for this reason we have everyone in listen-only mode. But in order for this to remain interactive, we have some polls that we'll run at the beginning. There's a questions pane where you can enter your questions, which we'll try to answer, and we'll do other things to help make this a little interesting. Later in today's webinar, we will stop to give away 3 gifts from our corporate supporters, Enjoy Life Foods and OK to be Peanut Free. The recipients of those gifts will be picked randomly from those still in attendance later in the webinar. And when we end the webinar, you'll see a survey, and please take that survey so we can use it to improve our program offerings. So today, now I'm going to introduce Dr. David Stukus. David Stukus, MD, is Assistant Professor of Pediatrics in Allergy Immunology at Nationwide Children's Hospital in Columbus, Ohio. Dr. Dave is also on the faculty of Ohio State University, and he's on the faculty of the Allergy Fellowship Program at Nationwide Children's Hospital and serves as a director of the Severe Allergy Asthma Clinic. Dr. Dave has a special interest in caring for families with food allergies, and he also serves as a co-chair of the Kids with Food Allergies Medical Advisory Team. You can find Dr. Dave on Twitter at AllergyKidsDoc. And I should tell you, Dr. Dave is pretty funny, so you're probably going to have some laughs today as well. So Dr. Dave, thank you so much for joining us here today. I'm going to now handle the virtual microphone over to you so you can go over the polls and get started on your presentation.
Okay, thank you so much, Linda. It's a pleasure to be here today, and thank you to all the attendees who are listening in now and later who will check us out online after we're done. So I'm trying to see, please interrupt if you can't see my screen. But it looks like as far as attendees, most of you are parents out there, as I am as well, and thank you all for joining us today. Hopefully we're going to have some very helpful information for you regarding food allergy testing. Looks like we also have some healthcare professionals as well. And then it looks like most people have undergone a variety of tests, including skin prick and blood tests, with some other types of testing as well. So we're going to cover all of that today. And with that, we're going to get into the meat of the talk. So what we're going to cover today is really diagnostic testing for food allergies. I will touch upon very briefly some conundrums that we all face as allergists and parents and people with food allergy about what to do about our symptoms and after oral challenges and things like that. Oops. So, but the bulk of this is going to be talking about different modes of allergy testing. And I'm trying to advance my slides here. Give me 1 second. There we go. So what we're going to cover today, really we're going to talk about a very important difference between allergy and intolerance, which causes a lot of confusion amongst folks. We're also going to talk about the different types of allergy testing as well as indications for testing and limitations in the testing that we have to offer. and we're also going to talk about how to apply diagnostic testing for food allergies. But before we get into that, I'd like to state something that's very important. Skin or blood testing of any kind, in and of itself, does not diagnose food allergy. We're going to talk a lot about allergy versus sensitization and ways to interpret the test, but this is the most important thing to understand before we move forward. A test result in and of itself means absolutely nothing without having the clinical history to help interpret the results. And this is an example of why. So this is a true story. I met this young man for the second time, actually, just within the last 2 weeks. This is a 16-year-old boy who has no prior history of food allergies, but while he was at school just a few weeks ago, he developed a rash. This started shortly after lunch. During that lunch, he ate a breaded fish sandwich, drank some milk, had some fruit and cookies. He didn't even know that he had the rash until he saw his sister in the hallway, and she pointed out and said, "Hey, you look funny." And he said, "What are you talking about?" He wasn't itchy, it wasn't bothering him. He looked in the mirror, and he was covered pretty much head to toe in this vague rash. He went to see his primary doctor the next day, and he was treated with steroids to help make the symptoms go away. Still wasn't bothered by it. Nothing had progressed. And his doctor said, "You know what, I want to evaluate you for fish allergy because that's what you ate at lunch, and that's the most likely culprit here." So he ordered a test called a childhood allergy profile blood test. And these are the results that came back. So as you can see on the left is you get this spectrum of foods that are included on this test that's touted as a screening panel. And on the right you get the levels of what the IgE is in the blood. And I'll talk about what this means in a little bit. And as you can see, almost every result came back with this big exclamation point stating that he was allergic. And what I find most interesting is that his doctor was concerned about fish allergy, and he ordered this test, but there was only one type of fish tested. And instead what he got were results for other types of things that he wasn't even interested in: milk, peanut, soy, tree nuts, wheat, egg white. Now, this is where the story became very unfortunate because the results were forwarded to the school. And the school personnel took it upon themselves to actually take this blood test result that they had, and they interpreted it by themselves, and they said that this young man has allergies to seafood, corn, peanut, tree nuts, soy, and wheat. He's never had any history of problems after eating these foods. And for reasons I still don't fully understand, they said the only thing you can safely eat in our school district while you're here is spicy chicken. Well, just so happens he doesn't really care for spicy chicken. Now, he actually got in trouble because he was sneaking other food throughout the day because the poor kid was hungry. He served 2 detentions because this blood test was done and because they diagnosed him with allergy. I was lucky enough to interact with them and catch wind of this, and I was able to see him 2 weeks after having the blood test was performed. So this didn't go on for months and months and months. I spent a lot of time in the office, and extensive history revealed nothing that was even remotely suggestive of food allergy. His mother shared a picture of his skin rash that she took on her cell phone, and it looked nothing like an allergic reaction. And I had the benefit of knowing that how long it lasted for and other symptoms and things like that, and this really looked just like a common viral skin rash. Skin testing in the office was completely negative for all foods, and we determined that he had very low likelihood of actually having allergy to any of those foods, especially the ones that he was eating without any problems. And I wrote a letter to the school allowing him to eat these things. So that's a very extreme example of how food allergy test results can be interpreted incorrectly. Now let's talk about a few definitions which really help clarify the picture about what we're going to talk about today. Now in regards to allergy, this is an immune response to an allergen, whether it's food or environmental, that results in reproducible symptoms every single time a person is exposed to it. Typically it's going to occur immediately. For the purposes of today's talk, when we talk about food allergy, we're really going to focus on IgE-mediated immediate hypersensitivity reactions, which are going to result with big red itchy skin rash called hives, can have swelling, difficulty breathing, difficulty swallowing, vomiting. You can actually pass out because you lower your blood pressure. What we all are familiar with, more than likely anaphylaxis, which can involve any one of these or more than one of these organ systems, and unfortunately people do die from allergic reactions. Intolerance is very different from an allergy. This is something where people will have symptoms when they're exposed to something, but it's not due to an immune response. Now when it comes to foods, this mostly causes gastrointestinal symptoms such as bloating, gassiness, can be heartburn, may have vomiting, constipation, diarrhea, and you can see how this can often be easily confused with an allergic reaction. But the biggest difference is there's no evidence of an immune response by any type of testing. This isn't always reproducible. This may be quantity related, this may vary over time depending upon other conditions inside the body, and this isn't always immediate. Let's go back to sensitization. So you heard me mention that in the beginning. Now this is the detection of IgE, and we'll talk about what IgE is in a second. So this is basically a positive allergy test result towards a specific allergen that doesn't take the history into account. So this is basically what our young man experienced. He had sensitization to multiple different foods detected on blood testing for IgE. You can also have a positive skin prick test or an intradermal test as well. I would ask everybody to repeat after me, but I'll take your word for it. Sensitization does not equal allergy. In case you didn't hear me, let me say it one more time. Sensitization does not equal allergy. What's that you say? You didn't quite catch what I said? One more time for those of you at home. Sensitization does not equal allergy. This is a huge, huge distinction and very important for everybody to keep in mind. Now, what does this Ig mean? Everybody says Ig, IgE, IgG. This is an abbreviation for a term called immunoglobulin, which is also an antibody. And this is part of our immune defense system. And there are different antibodies throughout the body that do different things. We're most concerned about IgE today because this is the allergy antibody involved in immediate hypersensitivity reactions. As you can see, this is the only antibody involved in immediate hypersensitivity reactions. It has no role in intolerance. IgG is a memory antibody. This is something that we form after exposure to viral infections, bacterial pathogens. If we get vaccinations, we form an IgG as a memory antibody. It is not involved in immediate allergic reactions, and it's not involved in any type of intolerance. This is the soldier that gets called to the fight whenever you're fighting off an infection that you've seen before. IgA is a type of antibody that really lives on the surface of our mucous membranes lining our nose and respiratory tract. It's sort of a first line of defense, if you will. This also has no role in immediate hypersensitivity reactions. We're going to talk about why this is important for celiac disease towards the end of the talk, though. And then we have IgM, which is really the initial responder, which helps mount our initial response whenever we see something that's foreign, but this also has no role in allergy or intolerance. Now, in regards to this IgE-mediated food allergy, this occurs to foods in roughly 5 to 8% of children, 3 to 5% of adults. I'm sure the audience is well aware of the top 8. So there are 8 foods that account for almost all forms of IgE-mediated food allergy, including cow's milk, egg, soy, wheat, peanuts, tree nuts, fish, and shellfish. This is not to say that you can't have allergy to other foods, because you certainly can, but these 8 account for almost all of the food allergy that we see. These reactions are objective, immediate onset, and reproducible at every exposure. There's no, I think I'm having a reaction. There's a, oh, I look at you and you look like you're having a reaction. And this is something that we use during our oral food challenges, which we'll talk about soon. Again, the typical symptoms will be big red itchy hives, swelling, upset stomach, vomiting, wheezing, anaphylaxis. The best test to determine whether someone is allergic to a food is what happens when you eat that food. IgE testing is best utilized to confirm a suspicious history. And delayed onset non-IgE mediated food intolerance cannot be confirmed with IgE testing. So if you order these tests or you try to interpret them without the appropriate supporting history, it's going to cause a lot of confusion, misunderstanding, and potential misdiagnosis. I hate statistics. I don't know if any of you in the audience are stats lovers. If you are, more power to you, but I'm going to do a very brief review because it's going to help set the stage for how we're going to interpret these tests that we order. So this is very easy, obviously. A true positive, you have the disease and you have a positive test. You have food allergy and your test result shows you that. True negative, you don't have food allergy and you have a negative test result. False positive is obviously you don't have a food allergy but you have a positive test result, so like our young man that I introduced earlier. And a false negative would be you actually have the disease but your test is negative. Now this is where I always get confused regarding the terminology, but I want to introduce it to the audience. So sensitivity is the probability that a test will indicate disease among those who have the disease. So you have a food allergy and you have a test result, that means it'd be very sensitive. Specificity is the percentage of people without a disease who are otherwise healthy who have a negative test result. The population at large does not really affect the sensitivity or specificity. This is a property of the test. However, the population and the prevalence of a disease will influence something called a positive predictive value and a negative predictive value. So it's just another way of predicting really the reliability of a test that you obtain. The more people with the disease, the more likely that you have a positive test with the disease with these. Now, a positive predictive value is an equation where you take the number of true positive cases over all positive test results. And really this is how likely is it someone with a positive test result actually has the condition. And a negative predictive value is just the opposite. Number of true negative cases overall divided by all negative test results, and then how likely is someone with a negative test to actually not have the characteristic. As we discussed before, as a general rule, any type of allergy test by itself is not diagnostic, and it's also not a useful screening test. Our young man underwent a screening test when they obtained that childhood allergy profile because they obtained a lot of different foods that they actually weren't interested in. As a general rule, IgE testing for foods has high rates of false positive results and a low specificity. Also, as a general rule, it has low rates of falsely negative results, with sensitivity greater than 90% and a negative predictive value greater than 90% as well. So what this means is that we tend to believe negative results, especially when the history is not suspicious for an IgE-mediated reactions, but we don't like to screen with a bunch of random testing because we get a lot of false positive results that don't always correlate with the history. So you really have to be selective and interpret with caution and in the context of the history. And when you don't do that, it can lead to big-time problems. Unnecessary dietary elimination, diagnostic confusion, people with chronic conditions especially that may have false positive testing, they take a bunch of foods out of their diet and they continue to experience symptoms without any improvement, then they may undergo more testing and more testing, take more foods out, and it can take on a life of its own after a while. Once again, sensitization is purely a positive test result, the detection of IgE toward an allergen. But the allergy or IgE-mediated hypersensitivity is the clinical symptoms upon exposure and the presence or detection of specific IgE toward that allergen. So I don't mean to repeat this to sort of beat a dead horse, but the reason I've said this several times already at the beginning of the talk is because this is a very important distinction. This often leads to a lot of confusion and misunderstanding both amongst patients, families, and even primary care practitioners who don't understand this distinction. So let's talk about the different types of testing that are available. So we'll start with skin prick testing. This is just a picture of one of the devices that are available. This has been available for almost 100 years, and it's been used widely for 40 to 50 years. This is where a small amount of allergen, whether it's a food or an airborne allergen, is introduced into the top layer of the skin, or the epidermis, with just a little prick device, and there's no needles. If a person has the specific IgE that is formed against the allergen, and it's connected to those allergy cells called mast cells, which live all throughout our body but are present in the skin as well, then that IgE will become cross-linked and it will release a chemical called histamine. And this happens pretty fast, usually within 15 minutes. Now, histamine does a lot of things in the body, but the biggest thing is it causes itching, it can cause redness and swelling, so it causes a hive. So if you have a positive skin prick test, I'm going to show you a picture in a second, you're going to get a wheal, which is the bump, and a flare, which is the redness, which is consistent with the presence of specific IgE. What's relevant is the size of the bump. A lot of people will have redness just from non-specific irritation of the skin during the testing, or they may have just some redness that really isn't very specific, but we want to see the size of the bump and compare that to our positive and negative controls. Most people will do a histamine control, which is we're just putting the chemical into the skin that would cause these symptoms, so we want to see that the skin is actually reactive. There are medications that can interfere with that. I'll talk about that in a second. And we also use the negative saline or other type of control where it shouldn't react, just to make sure that the person doesn't react to every test that we apply to the back and make sure that the testing is valid that day. So this is a little cartoon that shows you what one of these mast cells looks like. Inside these mast cells are all these preformed little granules that contain histamine, so that's why it happens immediately, because as soon as this is unlocked by cross-linking the IgE antibody, it releases the chemical immediately. And this is what it looks like. So as you can see here, there's a big bump here in the middle with the redness around there. This is, I'm guessing, this is the control over here, and these are the different types of allergens. So as you can see, just putting the test on the back will often cause a little bit of irritation and redness, but it's very important to interpret this appropriately, because this is obviously a positive one, this is obviously a positive one, and then this is more likely sort of indeterminate, and these are more likely negative. So just because you see the little dot doesn't actually mean that it's positive or clinically relevant. So this is something that is often causes a lot of confusion as well in regards to age and things like that, and it's something that I frequently am quoted as saying to residents and medical students and things like that. So when is the earliest the skin testing can be performed? And I like to say as soon as the shoulder is delivered, and here's why. So this is really based entirely on myth. It's reliable at any age, and there were studies, definitive studies shown 30 years ago that showed that skin is very reactive and reliable. And it's an accurate way to assess for the presence of specific IgE. Sometimes the size of the test result isn't quite as large in young babies less than 3 to 6 months of age, and then in anybody who's over 50 years of age. That can actually cause smaller than normal skin test size. A lot of young children have negative skin test results because they actually don't have allergies. So if they're tested for runny nose or watery eyes, they have non-allergic rhinitis and not pollen as the cause of their symptoms, or they're having other problems, lots of colicky behavior, gassiness, more GI symptoms. They actually have an intolerance, so they'll have a negative IgE test, or their symptoms just aren't consistent with it. So that's why a lot of these myths get perpetuated. And I also like to say that if you're old enough to have allergies, then you're old enough to have a positive skin test to confirm that you have allergies. Now, there are limitations, just like with any test. There's no perfect test, so don't get me wrong. None of these tests that we're going to talk about today are 100%. By no means are they. There are a lot of medications that may interfere with the results. We generally recommend that all antihistamines are stopped at least 5 days prior to having skin testing performed. This includes both short-lasting antihistamines such as Benadryl and long-lasting ones like Zyrtec, Claritin, Allegra, just as a few examples. There are other medications that can potentially interfere, including some types of antidepressants that actually have some antihistamine properties to them, and even some heartburn-type medications like Zantac can potentially interfere with the skin test results as well. However, most standard asthma medications like inhaled corticosteroids, even topical steroids, if they're used for short periods of time, singular albuterol are all okay to continue. Sometimes there's not enough good skin to apply the test. Somebody with terrible eczema covering their entire back or arms, we just don't have any place to actually put the test. That would be a significant limitation, is why we wouldn't be able to do skin testing. The size of the bump or the wheal can help predict the likelihood of that person being allergic, but does not necessarily predict the severity of the reaction. This is the same with the blood testing that we'll talk about next. We always compare it to the negative and positive controls. It can be uncomfortable and very itchy, especially if somebody has a lot of positive test results, because that histamine is being released, causing itchiness and irritation. And very rarely you can actually induce a more systemic reaction or anaphylaxis in very highly sensitive individuals. So if somebody comes in with a life-threatening reaction to peanut, for example, it may not be in their best interest to have a peanut skin test performed, and they can evaluate through other measures. But by and large, this is very safe to do for almost everybody. Now, intradermal testing is the next step after skin prick testing. This is where an allergen is injected deeper under the skin, as opposed to the top layer of the skin, actually using a needle, and you dilute it down and inject it in. This is really only indicated for airborne allergens, for venom and medications. There's really no role for intradermal testing, and I'll tell you why this is important as we talk about some unvalidated tests in food allergy testing. This can cause an allergic reaction or anaphylaxis in somebody who has a food allergy, so you should never want to do this. And if somebody ever recommends this to you, my advice is to run the other direction as fast as you can. This is not indicated for food allergy and potentially very dangerous. Now, moving on to blood testing. So this is formerly RAST, which is just a technique that was performed. Now it's done more through something called immunocap or an ELISA method. This is, I'm just going to say blood-specific IgE testing. So this is where you actually measure the level of IgE specific for the food or allergen through a routine blood sample. It's very convenient. You don't have to stop any medications. So medications will not interfere with this test result. You can test for several allergens at once, which sometimes is beneficial, sometimes it works against you, as we saw earlier with our case presentation. And you don't have to undergo the uncomfortable nature, and I say this tongue-in-cheek, of the dreaded skin testing, which can be uncomfortable for some people. Now, there are these commercial panels that are widely available, and they're marketed as excellent screening tools. You've already heard why I disagree that these are a good option for screening. You're going to get a result reporting essentially from 0, or 0.1, up to 100. So that's the range of the testing. There are these arbitrary classes that are often reported as well, and they'll say Class 1, Class 2, Class 3, Class 4, Class 5. These are completely made up. These classes actually have no meaning whatsoever, and often there's a huge overlap in the smaller numbers. So somebody can have a 1.5, which is a Class 2, and then they're at 1.7, it's a Class 3, and people may look at those classes and just misinterpret it. So the absolute value is the most important piece of information with this testing. And a lot of times what happens is you get a big fat red exclamation point with anything that's greater than 0.1, which induces a lot of panic and fear and concern from people who are trying to interpret these tests that don't have appropriate understanding of how to do so. In 2010, the Joint Council of Allergy, Asthma, and Immunology published food allergy testing guidelines. And they recommended, this is a wonderful document, there's the citation if you wish to look this up yourself. I just want to state one little quote. So the expert panel recommends serum or blood IgE testing for identifying foods that potentially provoke IgE-mediated food-induced allergic reactions, but alone these tests are not diagnostic of food allergy. A test result by itself is meaningless without the appropriate history. Now, blood IgE testing has very high rates of falsely positive results. This often leads to misdiagnosis, unnecessary dietary elimination, which can then lead to familial hardship, nutritional deficiencies. This is a wonderful slide. I'm just going to spend a second here walking you through it. So NHANES is this great trial, clinical study with thousands of people that they've collected information on over years and years and years. And as part of their trial, they collected blood samples and they evaluated them for IgE towards milk, egg, peanut, and shrimp, which, as we discussed, are 4 of the 8 most common food allergens. This is fascinating to me. What they found was that almost 30% of children and 15% of adults had detectable IgE, their cutoff was 0.35, to one of those 4 foods. That's 30% of children walking around, whereas, as you know from earlier, only 2 to 6% of those children actually have allergy. So if you just rely on the blood test alone, you're going to overdiagnose food allergy in almost 25% of kids, which is just unbelievable to me. Now, the values differ by food. This is something that a lot of people just don't understand. There are only established sort of definitions or cutoff levels for just a select number of foods. This is it, folks. Egg, milk, peanut, fish, soy, and wheat. There's been excellent clinical trials that we know that there's a certain cutoff point that can help determine whether a patient is at risk for having an allergic reaction or lower risk. These values have not been established for any other food, at least with any degree of scientific certainty or in a reproducible manner. So as you can see, the numbers vary widely based upon the food that you're evaluating. So you can't just look at a number and take it for what it's worth and say, oh, whatever test result you ordered, whether it's wheat or soy or peanut, a 3 means you're going to react. The numbers mean different things per different foods. And sometimes the numbers mean different things by different ages as well. And by the way, if you hand me a piece of paper that says, hey, Dave, my corn IgE was 3.5, what does that mean? I have absolutely no idea, because nobody's ever really done this sort of sensitivity, specificity, positive predictive value type studies on other foods. So really it's a shot in the dark, and we extrapolate our understanding from some of these foods. Now obviously the higher the test results, so as you know the test goes up to 100. So if you have a 99 out of 100 or a 90, then it's very likely that you're going to react to that food. But a lot of times what happens is you get these sort of wishy-washy results, 1.7, 2.1, 3 point whatever, and it can be very confusing even for experienced allergists to interpret. Now, if you spend any time on the internet like I do, you will come across multiple different informational sites or sites that are trying to sell you things or provide information. And for anybody who follows me on Twitter, you know that the misinformation and myths that are out there just drive me absolutely insane. For purposes of today's talk, we left any brand names or specific sites out of this. But there's one do-it-yourself allergy test kit. And this charges about $50. And they will detect IgE, it's a blood test, for egg, milk, wheat, mold, dust mite, 2 types of grass, 1 type of tree pollen, which is cedar, ragweed, and cat. They left dog off there and even peanut and things like that. If you look at the website, they'll give you information that says anyone with symptoms that may be related to allergy should take this test, including stuffy runny nose. I'll buy that for environmental allergies, itchy eyes, ear popping. But then they go on and they talk about headaches, seizures, stomach aches, and more. So it pretty much applies to anybody who comes across their website. As you know, this is not a good thing to do because it can result in a lot of false positive test results. So you must take the history into account. We have a very limited ability to predict future reactions when a food has never been eaten. Now, there is a very strong inheritance pattern for people who have allergies. So mom and dad have a history of asthma, environmental allergies, eczema, or food allergy, then it's much more likely that they will pass that along to their children. It's much less likely for children or siblings to inherit a specific food allergy. So just because you're allergic to peanut doesn't necessarily mean you're going to pass along peanut allergy to your child. But since it's one of the more common food allergies, if they're more likely to be allergic in the first place, then they may be more allergic to that. Peanut is sort of the one exception. So a lot of allergists will test younger siblings. So if you have a 3-year-old who has a known peanut allergy because of prior reaction, positive testing, and then they have a sibling born, a lot of us will recommend that we test them for peanut and tree nut before introducing it to them sometime around 9 or 12 months of age, because their likelihood of having peanut allergy with their sibling is much higher than the general population. But there's really little, if any, indication just to perform widespread food allergy testing before introducing foods. And I still meet with a lot of parents who come in my office, well, I don't know what they're allergic to, but that's why I want you to do the test so you can tell me. Well, time out for a second. It doesn't work that way. I can't predict the future, especially if you've never eaten a food. And if you are eating a food without having any problems, I'm not going to test for that food because I don't really care what that test result shows me. Because the best test is what happens when you eat the food. So when do we do this IgE testing? So if you have a history that's suggestive for immediate onset reproducible IgE-mediated food allergy reactions. Now repeat testing is very helpful as well. So if you have a known diagnosis because you have a clinical history that's very suspicious and you have positive IgE testing by skin prick or blood testing, a lot of times, in fact we should always, repeat testing over time. Skin prick testing doesn't offer the same utility as blood testing once you have an established food allergy because a lot of times the skin test will stay positive or you'll still get a wheal flare even if the allergy has resolved. This is not fully understood. We don't often know why. There may be something with memory cells in the skin. It may just be false positive test results. There may be more tolerance going on inside the GI tract or the gut as opposed to the skin. We're just not sure. But this is where repeat blood testing can be helpful because if you have a baseline at some point, you can compare tests over time, generally just once a year. It probably doesn't make a whole lot of sense to do this testing every 2 months to see where you stand because it's not going to change a whole lot. And we just don't want to put children through that testing unless we think it's going to be helpful. So generally about once a year or so, and you just compare the numbers over time, and you see a trend. Is your number going from medium level to lower or non-existent, indicating you might have outgrown your allergy? Has your number gone the other way and it's now actually higher than it was before, which indicates not that you're more severe, but that your allergy remains persistent. So it can be very helpful to track this. So one of the questions we received ahead of time, which is a great question, something we don't see a whole lot in clinical practice, to be honest with you, but it's something that's important. It really highlights the limitations of some of our testing. So how can you have anaphylaxis but negative testing? Well, maybe you tested too soon or maybe you tested the wrong things. So that's always a possibility we have to consider. Too soon meaning there is actually some evidence that there's this refractory period where if you have a severe anaphylactic or allergic reaction that all of your allergy cells sort of degranulate and then they can't really be primed again for a period of time, and some would suggest even 6 weeks after. And this is better established for people with venom anaphylaxis. We try not to test until at least 6 weeks after the sting because you can get false negative test results actually. The other thing is thinking about the properties of the testing components themselves and the extracts that we use. So for the most part, these skin and blood tests will offer either a mixture or they'll look at the major allergens associated with allergic reactions in the majority of people. But a lot of these foods, most of the foods, will have several different allergens that could potentially cause a reaction, such as minor allergens, which is pretty unusual to be honest with you, but it's still a possibility, and then our test that we use just doesn't test for that. In addition, if we look at foods outside the top 8, so I already told you about reliability of interpreting the blood levels for these foods and other foods, it may not have the most accurate testing, especially fruits and vegetables. So fruits and vegetables and these fresh foods, it's really hard to prepare a commercial extract for them because the proteins degrade very easily. So a lot of times we may even do like prick testing with the fresh fruit or vegetable in the office and actually just go through the outer layer of the fruit and then apply it to the skin like we would a normal skin test. So there may be some unreliability based on the food. And then there are extremely rare situations, especially in children, of you eat a food and then you have a specific activity like exercise and then you have anaphylaxis. But you eat the food without the activity and you're fine, or you exercise without eating the food and you're fine. So this is food-induced, exercise-induced anaphylaxis, which is extremely rare, especially in children, but there's always the possibility of that as well. Now the gold standard that we utilize are oral food challenges. This is the absolute best way to determine whether a food allergy is present because, as you've heard me say a couple of times, the most important thing is the history, what actually happens when you eat the food. So if you're not really sure about the history, or if you have skin prick and or blood testing with levels that indicate that it may be safe or unlikely that the person is going to react, then it's a good time or a good idea to think about doing an oral food challenge. We usually start very small. This is almost always done in a physician's office where medical supervision is immediately available. If a reaction occurs, we have medications available to help treat the patient, and then we increase very slowly. Now, our goal is to ingest about 1 to 2 servings, about 8 to 10 grams of protein. And then this is often followed by a larger open challenge. And I've seen some really weird things. I've seen somebody go through an entire shrimp challenge where they got up to 2 servings. And they said, all right, well, there's some leftover shrimp here. Why don't you eat 8 or 10 pieces and see what happens? They were completely fine. They ate the 8 or 10 pieces on the open challenge, and then they had anaphylaxis, which is totally bizarre. And I don't have a great explanation for it, but sometimes people may have just a different threshold. If they're outgrowing the allergy, it may be different for everybody. But that's why it's important to do these challenges in a physician's office. We're looking for objective evidence. So quick story about myself, and then I'll move on to the last part of the talk that I often share with families. So real hard part is we get, I don't know, 6 to 14-year-old children who reacted very early in age, and they've been told their whole life that they're allergic to a food. And then they meet me, and they come to my office, and they say, all right, who's this strange guy trying to feed me the food that's going to kill me? And they totally freak out. And I don't blame them. They should, because they think they've been told, if you eat this, you could get sick or die. So they've avoided it for years and years and years. And here I am trying to tell them that it's safe to eat it. So it provokes a lot of anxiety, not only for the parents, especially the parents, but for the child as well. What the anxiety does is it makes you feel funny. It can make you feel things that may or may not actually be there. So you can have subjective feelings. I was told from an early age that I had an allergy to sulfa drugs. That's what my mother told me, and I just took her word for it. It is what it is. So I walked around for 30 years thinking I had a sulfa allergy. Well, when I was doing my fellowship training and learning more about how allergies work, I said, I think this is bogus. I don't think this is real because of what I know about sulfa allergy and blah, 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 blah. So one day in the clinic, I said, you know what? I'm going to go ahead and just take it. I'm going to take it and see what happens. And I told my nurses, hey, if you find me in the back and I'm unresponsive, please jab epi in my leg and call 911. So I took sulfa drug, and for the first hour after taking it, I felt really weird. I did. I felt lightheaded. I felt tingly. I felt almost to the point where the room, like an out-of-body thing, and then it just went away. And that was the best example to me of the powerful connection that our mind can have with when you think something's going to happen, you almost will it to happen. So we're very careful about what we call a positive challenge. So I need to see objective evidence, skin rash, swelling. I'll take vomiting. You bought yourself a positive challenge with that. But a lot of times people will say, I feel funny, or I feel itchy. And a lot of times if we push through, those people actually do well. So that may be something that you encounter during your food challenges as well. Now let's talk about a relatively newer form of blood testing called component IgE testing. I'm sure a lot of the audience has heard about this. This is relatively new. It's best studied for peanut, and it's only available for a few foods. Now, as I mentioned just a couple slides ago, foods may have different allergens or components that can cause a positive, either as symptoms or a positive test result and or allergic reaction. Most of our testing really looks at these major allergens and doesn't necessarily tease out exactly what component of the food or the allergen is actually causing the symptoms until this component testing came along. So this isn't available for skin prick testing or standard blood testing. This is a special test that needs to be ordered and obtained. Now, this is best studied for peanut. And for peanut, what some excellent studies have shown is that there are 3 components, and ERA is the abbreviation for the major peanut allergen, ERA-H, and there's different numbers. It goes from 1 through 9. If you have IgE directed towards ERA-H1, 2, or 3, this is strongly associated with the risk of allergic reaction or anaphylaxis if you eat the peanut. However, if most of your IgE is directed towards ERA-H7, 8, and 9, and 1, 2, and 3 are negative, this is much more strongly associated with cross-sensitization with tree pollen and much lower risk of reaction to peanut. Now, the applicability of this is, I don't think it's ready necessarily to be widespread. I think there are certain indications where this can be very helpful. If you come in and you ate a peanut and you almost died from eating that peanut, this test probably won't provide a whole lot of benefit because nobody in the right mind is going to suggest that you eat the peanut again until your IgE level is very low, if it goes away at all. However, if you happen to have had screening testing performed for whatever reason and you had a peanut level that was sort of in the mild or moderate range, but you've never eaten peanut, or the clinical history is very questionable, then this testing might be helpful to help tease out what your true risk of reaction is. Patch testing is another form of testing. It has nothing to do with IgE. This is delayed T-cell mediated reactions consistent with like a contact dermatitis, most commonly be nickel or cosmetics. This is where the allergen is actually taped to the back and left in place for 2 days. Then you take it off and you read the skin 72 to 96 hours. There's no role for this in the evaluation of IgE-mediated food allergies. This has been evaluated for chronic conditions such as eczema and eosinophilic esophagitis. The scientific evidence has sort of been all over the place in regards to the utility of patch testing. There are certain academic centers that are strong believers in patch testing. There are other places that don't perform patch testing at all for these conditions, but this is something that you may come across. It's very difficult because patch testing for foods really has not been standardized, validated, and the results are often variable within the same person even over time, and they have low predictive value. So it's a piece of the puzzle. It is certainly not the end-all be-all. This is what it looks like. You put the tests on the back in these little discs called fin chambers. You can really put anything on there, whether it's metals or rubber or latex or foods, and you just leave it on the back, and then you take it off, and if you have a positive test result, you get a big reaction at the site wherever that specific allergen was applied, and you can see what the negative ones look like. Now what about this IgG? So if you spend any more time on the internet and you don't see the at-home test for IgE testing, you will see at-home tests for IgG testing, or you'll meet potentially certain practitioners who recommend IgG testing for food allergy or intolerance. This has been touted by many as a useful tool. However, IgG is a memory antibody. This really signifies exposure to the products, not an allergic reaction to products. It may actually be a marker for food tolerance, not intolerance, and that there are children who have outgrown their cow's milk allergy, develop tolerance, they actually have elevated levels of IgG, showing they actually can tolerate it now. And from that same paper I quoted before, 2010 Food Allergy Guidelines, IgG and IgG subclass antibody tests for food allergy do not have clinical relevance, are not validated, lack sufficient quality control, and should not be performed. This is not recommended for anybody in food allergy. But if you go on the internet, and we've removed the names, there are different sites that you can actually do at-home testing. And this is one example. This is a direct quote from the site. Nearly 1 in 3 people have a food intolerance and don't even know it. But take advantage of our special offer to find out if something you are eating is affecting your health. Now this one has a low price of $450. And they will scan you for 250 foods and additives. I won't go through the whole list, but it's pretty comprehensive, and it pretty much encompasses anything anybody can ever encounter, including octopus and perch and red snapper and all these different types of food additives and chemicals and things like that. I have one slide, but I'm going to go through these tests individually on experimental or unvalidated tests. So there are tests such as these that are touted by many non-board certified allergist immunologists for the evaluation of food allergy. One of these tests includes basophil leukocyte. These are just different types of immune cells in the blood. You take the blood and then you measure histamine release when it's exposed to a certain food allergen. This has not been validated. This is certainly not available for widespread use. It may have a very limited role, but it should not be available for most to use just because it's very difficult to interpret, if at all. A cytotoxic test is where somebody will take your blood sample, kind of spin it down in a centrifuge, and then they're going to put it on a slide. And then they're going to expose your dried blood or your separated blood to different types of allergens. And then they're going to look at it under a microscope. 10 minutes, 20 minutes, 2 hours, 4 hours. And if the cells change in shape or if the cells disappear, then that would indicate that you are sensitive or allergic to whatever you're exposed to. There is absolutely zero scientific evidence to support this testing maneuver. Skin endpoint titration is a form of intradermal testing where they will actually take an allergen and they'll dilute it down, continue to inject it into the skin basically until there is a reaction, at which point that would be your threshold dose in which immunotherapy would be recommended for environmental allergens, not for foods necessarily. This causes a lot of false positive and irritant reactions in people who may not have allergy. Applied kinesiology is a test that some practitioners will tout as a way to diagnose food allergy or other allergens. They'll have you hold something in your arm, or if it's a young child, they'll have the child hold it or you hold the child on your lap, and then whatever you're holding in your arm, they'll do muscle testing, and if there's a weakness on that side, then this would indicate that you're allergic to that substance. Again, zero scientific evidence to support this testing. Provocation neutralization is actually where they will inject something at a very dilute amount into the body, and they will see if they can provoke symptoms. And whatever dose that they provoke symptoms, then they can actually start their immunotherapy there to actually neutralize those symptoms, often touted for a lot of vague subjective complaints, fatigue, things like that. There's absolutely no role for food allergy testing. And electrodermal testing is basically subjecting the skin to various electrical currents and machinery that then gives you a readout of what you may be allergic or sensitive to. This is also not supported by any scientific evidence whatsoever. Now, we're going to wrap up by going through some non-IgE mediated conditions and testing, and this is where I expect some of the audience to get a little confused about some of the things I'm going to say, but I'll try to be very careful with how I explain myself because there's a limited role for testing, and this is why you're probably confused about some of the test results you may have received for these conditions. So we'll start with eczema. So this is a chronic skin condition. It's not caused by allergies. This is a big misconception. It can be triggered by things people are allergic to, including environmental things and foods, but this is caused by DNA. This is something people are born with, and they have an altered skin barrier. Their skin is defective, for lack of a better term, and it leads to chronic loss of water and moisture from the skin and a very vicious dry and itch cycle that causes inflammation, waxing and waning symptoms over time. As a general rule, children with eczema have very high total IgE levels. It's floating around in the thousands, and this can cause very high rates of false positive skin or blood-specific IgE tests. So if you have a total IgE of 1,000 and you try to detect a specific IgE to something, you're often going to get a lot of background clutter that may or may not mean anything. Skin testing may not be reliable because in patients with severe eczema. Now this is where it gets confusing because kids with eczema certainly have a much higher rate of food allergy. And for children with moderate to severe eczema that doesn't get better with standard skin hydration, topical steroids, things like that, a third of those will have food allergies as well. Now, most of these are going to be immediate onset, typical hives, swelling, difficulty breathing, anaphylaxis. But for some of them, it can be I eat a food and my skin is really, really bad. And then I take the food out of my diet, my skin gets a lot better. You're not cured, but it gets better because that was a major trigger for you. History is often unreliable. Skin and blood testing is often unreliable as well. Now, we often do these tests to see if we can tease out a very strongly positive result that may help indicate that. But sometimes you need to actually consider food elimination trials with clear endpoints. Take a food out of your diet for 3 to 4 weeks. If your skin clears up completely, maybe it was that food. Or you take out several foods and put them back in, things like that. But this can be very difficult to tease out. Eosinophilic esophagitis is another chronic condition that's been relatively new over the last 10 years as far as description diagnosis. You really need 3 things for diagnosis. Symptoms, upset stomach, heartburn, food getting stuck in your throat while you're eating. You have to be on a trial of a medication called a proton pump inhibitor for at least 8 weeks because there's a lot of people with those symptoms that everything goes away after taking this medication. And then you have to have a biopsy of the esophagus that shows that there's greater than or equal to 15 of these eosinophils, which is an allergy or an inflammatory cell that doesn't belong in the esophagus. So you have to have all of those. So a lot of people will get the scope during having their tonsils taken out and have evidence of eosinophils. That's not E unless they have symptoms. A lot of people have symptoms, but they don't take the trial of the proton pump inhibitor. That's not E either. These folks are in general very allergic, lots of environmental allergies, may have evidence for food allergies, but generally don't have the IgE-mediated food allergy history. Interestingly, almost everybody gets better when you take food completely out of their diet. The hard part is that's when the treatment becomes worse than the disease because it's very difficult to sustain a lifestyle without eating any food. Now we're talking elemental formula, sometimes putting a tube from the nose down the stomach to supply feeding and things like that. It can be very difficult to determine exactly what food may be triggering it, especially by history, just like eczema, very unreliable. Sometimes skin prick testing or blood testing or patch testing can help, but oftentimes it's unreliable. But for a lot of these people, they do have foods that are triggering it, and we'll do these tests to try to tease it out, but sometimes it just goes by dietary elimination and trial and error. So the testing can help, but it's not always reliable. Food protein-induced enterocolitis syndrome, abbreviated FPIES, is an immune reaction to foods. It just doesn't involve IgE. This almost always occurs initially during infancy or by a year and a half of age. This presents with delayed onset vomiting or diarrhea and dehydration that occurs 1 to 3 hours after eating a specific food. There are no tests available to diagnose this. All the IgE testing is completely negative, as it should be because this is not an IgE-mediated condition. There's really no role for any other type of testing, including the IgG testing or some of the other tests we talked about. We go by the history, and most of the time, which is very fortunate, these children are able to tolerate these foods later in life after about 2 or 3 years of avoidance. So we'll rely on food challenges to help guide the diagnosis. Then we have food intolerance. So this is, again, non-immunologic adverse effects after eating a specific food, mostly GI symptoms, difficulty of digestion. There's really no indication to perform IgE testing, and there's really no currently available tests available for diagnosis. There's an overall lack of good evidence that has established a role of foods causing non-allergy-related chronic autoimmune or inflammatory conditions, including rheumatoid arthritis or multiple sclerosis or Crohn's disease, with the one exception of celiac disease, which is what I'll end with here. Now this is actually an autoimmune condition, has nothing to do with IgE-mediated hypersensitivity, so it's not technically a food allergy at all. But what happens is people will form these IgA antibodies against their own tissue, specifically these cells that line the intestine. It can cause bloating, weight loss, diarrhea, skin rash when these people consume gluten, which is something that's present inside wheat, and other substances as well. Now, there's blood testing that can be performed to detect these allergy antibodies. You have to be careful if somebody actually has IgA deficiency, but really a lot of people recommend that you do a biopsy and actually look for evidence of damage in that part of the intestine while they're eating gluten. If you take gluten out of the diet, people get better, and the body can actually start to repair itself, and the treatment is really a gluten-free diet, making sure that they don't eat it. This is very different from the risk for anaphylaxis. This causes more long-term inflammation inside the body for people with celiac disease. So in conclusion, then we'll have some time for some questions. Allergy testing in and of itself is not diagnostic for food allergies. Allergy testing is not a useful screening test, and allergy test results need to be interpreted in the proper context, and the history is the most important predictor of future reaction. So with that, I thank you all very much for your attendance today. I welcome questions. We already have some questions. I think I'm going to turn it back over to Melanie and to Linda at this point, but thank you all very much.
I think I'm back online here. Thanks, Dr. Dave. What a wonderful presentation. We've already got a lot of people saying how helpful it's been. And of course, all this stuff just generates more questions, so we've got a lot more questions. And some of them we anticipated from before when people registered. They actually submitted questions. So we're going to start with those. And it is already 1:55, so we need to not extend too long to get past the hour to respect everybody's time. So the first one we're going to do is if you're diagnosed with a food allergy, do you need to completely avoid the allergens?
Yes. If you have a food allergy, the only recommended treatment is complete and strict avoidance of that food allergen, because every time you eat that food, you could be at risk for having an allergic or anaphylactic reaction.
Okay.
That was easy.
Okay, this one is one we actually got a few more people asking during the presentation. Why might a control be negative on skin testing, and what does that mean about the test results?
So if your histamine control is negative, it means usually one of two things. One is you still have some antihistamine type medication in your system that's interfering with the test results, which says that you probably can't interpret the rest of the results, or at least have to interpret them with caution. Or perhaps the control was bad, or the extract itself may just not be as potent, or it just wasn't applied with enough pressure. So we'll see that a lot as well, because people may wiggle as it's first put on. But a lot of times you'll still have other positive test results that you can still look at, because it's very obvious you'll have a big wheal flare. So it's very helpful to look at and to help determine those things.
Okay. Do seasonal allergies affect skin or blood test results?
Absolutely. So the best example is peanut, and as we talked about with the component testing. So if you have a history of tree pollen allergy in the springtime, itchy, watery eyes, sneezing, runny nose, and you have birch pollen allergy, that can cause an elevated IgE towards peanut, which may or may not be clinically relevant. So we see this all the time, especially with fruits and vegetables. There's a lot of cross-reactivity and cross-sensitization that can cause falsely positive test results that may actually increase during the particular allergy season.
Thank you. Do kids with mast cell disease respond differently to food allergy testing? You might need to explain for the audience what a mast cell disease is.
Yeah, so we talked about those mast cells before. These are really the allergy cells. For some people with mastocytosis, they have an abnormal number of mast cells, and they sort of respond differently, and they release histamine on a frequent basis, which can cause anaphylaxis or allergy-type symptoms. It's interesting because people with mast cell disease don't necessarily have an elevated risk of having allergy specifically, but if they do have allergy or food allergies, they are at risk of having a more severe reaction, if that kind of makes sense. And if you're applying, so blood testing should be very reliable. However, with the skin testing, you may get non-specific irritation and false positive results because their mast cells are very sort of hypersensitive to begin with. So it can result in false positive testing.
Okay. Next. After diagnosis, how often should food allergy testing be repeated?
I usually say at least once a year just to see, because about 20% of people, even with peanut, tree nut, seafood allergy, will develop tolerance over time, and much more with milk and egg allergy, up to 85% by school age will develop tolerance. So it's important to follow it and not walk around the rest of your life thinking that you still have an allergy, which may not be there. That being said, if you have a known peanut allergy and your level on blood testing is 100 or greater than 100, you probably don't need to repeat that every year, but it's still worthwhile, repeating every 3 to 5 years, because you never know what may happen over time.
Okay. Next. If my child tests positive to a food but has eaten it without reaction, is she at risk for developing an allergy to that food in the future?
So this happens all the time, and there's actually some case reports and evidence that if somebody has detectable IgE by skin or blood testing, and they're eating a food without problems, but then they stop eating that food. So like the young man I introduced at the very beginning, and then you leave it out of your diet for a few months, but you still have the IgE. When you eat that food again, you may be at risk for developing a reaction. We don't really have a great way to quantify this or know how often this occurs. The best advice to give, number one, is don't test for a food that you're eating without problems because you don't want to know what the answer tells you. And two is if you do encounter this situation, keep eating the food because that's probably the best way to maintain tolerance. There's a lot that we don't understand about this interplay of having IgE and eating without problems, but it should not be removed from your diet unless it's actually causing symptoms.
Okay. How do you know when a child is ready for a physician-supervised oral food challenge? And a related question somebody asked a couple of times while you were speaking was, should a doctor always run skin or blood testing before making the decision to do a food challenge?
So it depends on the history of the reaction, the age of the child, and the combination of the testing results. So when the testing results, I would recommend yes, because that will really help indicate whether it's safe to do in the first place. But if the history is not suggestive at all of having a IgE-mediated or allergic reaction, then a lot of times you can, recommend the challenge even at home. Best example would be, I don't know, if food was taken out because of a possible, itching when they ate it without any other symptoms or something like that. That's a bad example, but so you have to take all those things into account.
Mm-hmm. So the food challenge, a couple people were asking about food challenges at home, but you would only do those under specific instructions of your doctor.
That's case by case and with specific supervision and instructions from your doctor, absolutely.
Okay. Next. Why does my child test positive on one test and negative on the other?
So keep in mind, no test is 100% either way in a positive predictor or negative predictive value. And a lot of times what happens is on the blood test you get these very low level numbers, less than 1 or less than 5, which may just be a non-specific background clutter from the test itself. And then when you actually do the skin test to see if the IgE is there and attached to the skin, the mast cells, then it's negative. So the most common answer is that the blood numbers are just really, really low and don't mean anything.
Okay. What is puddle testing? My allergist wants us to bring in fresh foods to our appointment for puddle testing.
So I hadn't heard of this term until this morning, actually, when I got the question in advance, and I had to look it up. But it's something that I've used myself over and over again. So this is really testing the fresh food, and you take the fresh food. Puddle would be more of a liquid, and you actually just put a little dab on the skin, and you observe for any type of reaction. The puddle test itself probably has very limited utility. It can cause a false positive response in somebody with eczema or just very sensitive skin, and it may not actually indicate risk for an allergic reaction after they eat it, or it may actually be falsely negative, and it may provide reassurance when it's really not indicated. You really need to do the prick testing. So an extension of the puddle testing would be to take fresh fruit or fresh vegetable and do a prick. So that's probably the best way to really evaluate this. But this isn't something that is certainly first line. This is something more to help really tease out a very difficult history or some test results that are all over the place.
Okay. My daughter's IgE numbers are off the chart. She has eczema and asthma. Since the tests have high rates of false positive, what's the best way for us to determine what food she's allergic to?
So depending upon the levels, this is where it gets stuck. Sometimes our hands are tied. If you come in to meet me for the first time with this story and your specific IgE towards foods are very high or greater than 100, we're stuck because I can't in good conscience necessarily recommend that we do a food challenge. But food challenges, in this case, can be extremely helpful to really tease out what's real and what's not real. So it all depends on the level of the testing, the size of the tests. We talked about the cutoff points earlier for blood testing. We also actually have cutoff points for the skin testing that can help predict whether this is going to be a true allergic reaction or not. So if they're really significantly positive or elevated, sometimes you're just stuck avoiding it. Sometimes you actually have some wiggle room to think about challenges.
Okay. My son's test for dairy is over 100, but mustard was only 1.92. He has severe reactions to both. I thought a lower number would mean he had a better chance of not reacting.
perfect example of how the number by itself does not correlate with severity. There are people with severe reactions to very low numbers, and there are people with very high numbers that don't have severe reactions. The numbers are a guide to help determine the likelihood of a reaction. If they've had a reaction, severe reaction to mustard, that's the best clue, and then we use the test to help confirm that.
My son's test for dairy, oops, there we go. I recently heard 2 stories about people passing a food challenge and then a few years later the allergy returned. Is this something to be concerned with, or why is this important once you pass a food challenge to continue always keeping the food in your diet?
So this really delves into a lot that we don't understand, and this is, we did not talk about treatment, we didn't talk about the food desensitization protocols, and there's a purpose behind that because that would take a whole hour by itself. But as those studies come out, what we're finding is we really don't understand what's going on with a lot of these people. So while this is unusual, it's not unheard of. The best way is to continue to eat the food. Whether that promotes tolerance or who knows what, I don't know, but as a general rule, you're either allergic or you're not. If you're no longer allergic, you should be able to eat the food without any problems. To have that same allergy return later in life is a bit unusual, but I don't really have a great explanation for that, to be honest with you.
Okay, well, I think that's it. Thank you so much, Dr. Dave. I really sincerely appreciate it. This has been terrific. You've covered so much territory. So what we're going to do now is do our giveaways, and we have 2 winners of OK to Be Peanut-Free items, and that is Adrian Livingstone and Diane Perez. We'll be in touch with you to confirm your contact information and get that shipped to you. And then we have 2 winners of Enjoy Life prize packs, and that is Katie Copenhagen and Shane Splonskowski. I hope I pronounced your name right, Shane. So I'm going to go ahead and wrap up. I know it's already past 2 o'clock. What we want to do is make sure that you're familiar with the fact that we have a website full of educational resources for you, including all prior webinars that we've recorded. We have other videos, other printables that you can check out, and lots of educational articles. Blog posts, our medical advisory team do all kinds of good stuff. So the archive of this webinar will be available in a couple of days. We'll be sending out a follow-up email with a link to this archive with additional information to supplement this webinar discussion. Some of you had asked about food challenges. We have a great blog post about that and some other things, so we'll include that in the follow-up. So the next thing that we'll be doing in terms of upcoming events is actually next Tuesday evening at 9 o'clock after the kids are in bed. We're going to have a Facebook party with So Delicious Dairy Free, and they'll be answering your questions, and we'll be having some giveaways that evening as well. So you can sign up by following this link that's on the slide. We'll include that in the follow-up email to you with the webinar archive, and we hope you'll join us then. And then our webinar in June is going to be May 20th, and it's sweets, treats, and savories free of milk. And it should be fun. We're going to have the So Delicious Dairy-Free team there to share a lot of information and recipes and things like that on how to use dairy-free substitutes. I think it'll be really terrific and informative. So in closing, we just want to remind you that we really sincerely appreciate you for joining us. Thank you, Dr. Dave, for doing a wonderful presentation. Kids with Food Allergies is a division of the Asthma and Allergy Foundation of America, the nation's oldest and largest asthma and allergy charity. If you find today's webinar valuable, please work with us to continue this webinar series and keep us in your charitable giving plans. So thank you again for being here with us today. We'll be sending you that webinar archive in a few days. Bye.